things about the tongue, which we should just preface our remarks by saying it is a remarkably complex neuromuscular vascular structure. So it's a remarkably complex bit of anatomy, and we kind of take the tongue for granted. But if you remember, for this wonderful part of our body, what are the functions from our mouth down to the beginning of our lung? Well, there's three things. We have to be able to breathe. We have to be able to eat liquids and solids. We have to be able to talk. Those are three things that take place. And the tongue is involved with all three of those. It is. An example, when we think of nutrition, we need a good functioning tongue that tells us about the temperature of food, the texture, and the taste. And we take those things for granted. But here again, this complex neuromuscular vascular structure does that. So we know when something is too hot or too cold. We know if it's rough. We know if it's really off taste. Say, oh gee, what did you do to that when you made it? The other thing that the tongue has to do is it's involved in swallowing. There's an oral phase of swallowing. Without the tongue, we can't bring whatever we chew to the back against our palate to go from the oral phase to the pharyngeal phase of swallowing. It's not possible. You have to have the tongue working, and you take it for granted. The other function has to do with speech. Well, one of the obvious things, you've been called to see a child who has a very, very tight lingual frenulum. Mm-hmm. Well, that child is going to have trouble with articulation. So that is a simple, direct, common status of the tongue that has to be addressed, because they will not be able to master speech real well. And there's numerous children that don't have particularly tight lingual frenula that are in speech therapy at school with articulations problems. It usually gets solved with a good speech pathologist in time and encouragement. And even the process of being a dramatic singer, you have to have extremely good, intricate, coordinated lingual activity. You're not going to sing very well. Mm-hmm. Or another example is some elderly person who has a central nervous system accident, and they lose their ability to talk after a stroke. So that's a function. So we talked about nutrition, talked about speech. How the devil does respiration fit into this process? Well, one thing that we do know about the tongue, and that is in people who have sleep apnea, the base of the tongue is an enormous structure, and it frequently just falls to the back because it loses its tension. And it's a major cause of obstruction in producing sleep apnea, in addition to what might happen in the palate and the tonsil area as well. So that's involved with breathing. If you can't breathe, you're going to have depleted oxygen levels. In the middle of the night, you'll have some cardiac arrhythmia, and you won't make the breakfast. So the tongue is involved in that way with the process of respiration. One other thing that I should mention, because it comes up in discussion, what about, you say the tongue does things naturally? Yes, and unless there's discomfort in the tongue in relationship to taste, or unless there happens to be an unusual taste overall in the mouth and someone spits up some blood, generally ones that, so it's pain, secretion that's disturbed, or an obvious trouble with speech that might be tied into other neurologic findings. People don't tell you much about the tongue, but on your exam of the tongue, or they may bring it up, you might find little fasciculations of the tongue. And the question is, are they significant? They could be. anyone who has fasciculations of the tongue, you always have to think of causes. Now, there are people who get tongue fasciculation because of fatigue or extreme tension, and although in this day and age it's not commonly seen, people, at least years ago when they didn't have these sophisticated blood tests, would have fine fasciculations from deficient vitamin B12. But the one that we know is manifests itself almost always initially with real fine fasciculations is ALS. Never forget that. Patients that I've seen with ALS over these last 50-some years have all had, sometimes the first manifestation, are uncontrolled fasciculations of the entire tongue.
Could you explain to me just real quick what you mean by fasciculation?
These uncontrolled wormy-like motions.
Okay.
And they can be very, very fine. And sometimes they're aware of them, sometimes they are not, but they're persistent. Now, I'm not saying they all have ALS, but the ones we've seen, several years ago we had a very accomplished colon surgeon here that subsequently died, and he presented with a little disturbance in his speech. When I saw him, he had these fine fasciculations, and he went on to have ALS. The other one that you want to be at least aware of, because there's so many of these neuropsychiatric drugs that are given to everybody for bipolar, is this condition called tardiva dyskinesia. It's real. And then they have these funny motions with their tongue, their mouth and all, and I tell you, it's not rare. And they're usually on neuropsychiatric and even antidepressive medications. Now, it's not common, but you want to be careful that you don't overlook that, because it does occur. Well, going on then, this is just a picture of the dorsum of the tongue. This wonderful dorsum of the tongue, and these wonderful little elongated keratinized mucosal structures are called filiform papillae, and they tell you all about the texture of food that you're eating. And that's why you can put something in your mouth, you may not even seen it on the end of your fork, and you can tell what the texture is. And it's important, because if you can't appreciate texture, you may not be able to spit something out that's real rough and you don't want it in your mouth, like a little tiny few grains of sand or something. You don't want that in your mouth if you're eating some fish of some sort. So the texture is important. And then, of course, the modalities of taste, of which there are 5. We have these wonderful tiny little dots all the way through here, these fungiform papillae that appreciate things that are sweet and salty. And then the circumvallate papillae, the things that are real bitter, like the most common bitter thing would be a poorly brewed coffee would be bitter. And that would be, you pick up that. Or something real sour, probably the most common sour thing, well, it's not the most common, but it's relatively common, is rhubarb. People love rhubarb. It's really quite sour. Sometimes that's why they like it. They like sourness. And then the last one is glutamate, MSG. It's considered the 5th taste. It's sort of a meaty, enhancing, flavorful thing that is sometimes combined with things that are sweet and salty and bitter and acidy, and so you lose it, but it is a distinct, it's now been accepted as a distinct taste, the amino acid glutamate. And it's in a lot of foods, particularly Asian foods. They like it. Although there's some people that seem to react to it, so a lot of times I think, and I'm not an authority, but they portray a lot of disturbances from MSG that maybe are not factual. So that's the dorsum of the tongue. And it's, like I mentioned, it's this incredible neuromuscular structure loaded with a lot of blood, and it works just fine. Now here's the base of the tongue right here. You see the anterior 2/3. This is the entire base, and it carries on clear to the back, where there's the circumvallate papillae and the foliates are behind. And that's the base of the tongue. We spoke about that a moment ago, as to the weight of that structure that could fall to the back, producing obstructive sleep apnea. It's one of the real features, along with what might happen here was loss of tension on the palatal folds and the soft palate. Now this is the undersurface of the tongue, which you should never neglect. And of course there aren't any taste buds here. But you see the frenulum, and then you see this remarkable vascular network, which truly makes the tongue a very vascular structure, which is great. You want it to be a very vascular structure because it works in all of its reparative activity. Sometimes you'll find these little tiny ribbons of mucosa which mean nothing, and some people will notice this intense venous supply, which is, again, part of the vascular network of the tongue. And we spoke about the lingual frenulum affecting speech. Obviously, this is a very free lingual frenulum, but in children sometimes that has to be cut back so that this articular mechanism here that controls good, clear speech works appropriately in the oral cavity. Now, obviously, if you look at the floor of someone's mouth and they may not have any complaint, and you see something like this in the floor of the mouth, you'd say, well, that's certainly not normal. This is just an exam of intense leukoplakia and ulceration. That would alarm anybody, and probably wouldn't be anything that as a provider here in the apostolate you'd be unaware of. Someone who abuses their mouth with tobacco and alcohol. That would be something that should be addressed in terms of making a tissue diagnosis, particularly where it's ulcerated in through here. Here's something that is not common, but we saw. I think you had a case several months ago of this white spongy nevus on that young man. Do you remember that? This is an inherited dominant characteristic that seems to have this symmetrical. It's totally benign. It's genetic, dominant genetic, and it's referred to as Cannon's disease. Now, Dr. Lloyd had one of these about 6 months ago. It may take another 2 or 3 years before you see something like this. This is in no way precancerous. It can occur here. It can occur in the cheek area. It can occur on the other surface of the tongue, the dorsum of the tongue. Entirely benign. It doesn't necessarily grow. It's just there. Here's our old friend, the tongue. I think the tongue's almost like fingerprints. Everyone has a different tongue. This is a tongue no one's complaining. The space is not complaining, but it has all these nice big clefts and fissures in it. There's taste buds here. Probably has no complaints whatsoever. Can eat and appreciate texture, taste, and temperature. But sometimes the appearance is alarming. That's why I would believe people shouldn't look at their tongue unless there's a complaint, because it'll change constantly from week to week.
I agree.
I also don't believe, contrary to what the dental people, in brushing your tongue or scraping it. Why? Because it's too traumatic. It's too traumatic to these sensory structures. Not necessarily the taste buds, but the tongue is a very sensing structure, and if you keep brushing it, you traumatize it. It's of no value as far as I'm concerned. The filiform papillae that we saw on one of the first sides will break off depending on what you eat, particularly if you eat a variety of foods that have different texture and substance to them. They'll break off and they'll grow back. It's kind of nice to see that. Although years ago, when the country doctor used to say, all he could say was stick out your tongue, he wanted to see how thick the filiform papillae are, because they were extremely thick and had not broken off. That would indicate that you've not been eating well at all, because you've never had anything in the form of friction to break off the ends. So if you had a coated tongue, that was an expression in the medical literature years ago. So-and-so had a terribly coated tongue and was sick for a month and then went and expired. Well, it was coated because he wasn't eating. He may have had a number of medical conditions that didn't prompt him to eat in terms of his appetite. But this is very normal. Here again, you say, well, something adverse is going to happen. Isn't something going to get caught in all those? No, they won't. They will not get caught there. The tongue is remarkable in its activity. We know that when we bite our tongue, you can imagine why don't we bite our tongue? The clearance between our tongue and our teeth is just a few micromillimeters. When we close our mouth, think if we're eating in a hurry and laughing and watching TV, you think, well, we should bite it all the time. This is our old friend, the geographic tongue, which is, again, totally unexplained, where some of the filiform papillae fail, they'll come away and then they'll fail to resurface themselves. We don't know why. It's a genetic trait. It doesn't contribute to any discomfort of the tongue, but except the appearance. Look at this. There's no filiform papillae here. And they're responsible just to appreciate texture, not anything that is in the five modalities of taste. But this will change, and it'll be over here in a month, maybe in the back in a month. No consequence, except someone is looking at their tongue constantly. With regard to taste, there's one condition that you will find, we may have mentioned this before, there are people who have what is referred to as the burning tongue syndrome. It's very real.
I have a patient that had that.
Yeah, burning tongue syndrome, right, it's real. And it's usually a burn effect that they get right here in front. And yet, you'll say, can you taste things that are salty on vegetables? Yes. Sweet, just in the frosting? Oh, yes. And anything that might be real bitter? Oh, yes. They have no trouble tasting, but they complain endlessly of bitterness here on their tongue. And often they've had extensive workups, they've had all sorts of blood tests, they come up with nothing. It's a very real condition. And after an extensive medical workup and nothing is found, and they're not abusing their mouth at all, generally they're not smokers or drinkers, they're usually people that are very meticulous about the care of their teeth and their oral cavity, but they end up with a burning tongue, and it can go on for weeks. And the vast majority of those people are suffering from depression. And they should be put on antidepressants. It takes a while to resolve, but it generally will resolve. You may have to adjust the dose accordingly, but it does occur. Here's again an awful looking tongue, but it's of no consequence. It just shows a traumatic pattern of geographic configuration. And of course the tongue has to fit in the mouth. There are a few cases where the tongue is so large you can use the label macroglossia. Not common, but there are some uncommon conditions. Probably one of the more common ones in adults with people who have amyloidosis can cause that. And again, not a common finding. Some people can have structurally a large tongue. It fits carefully, the teeth indented, and it fits fine. Most of the disturbances that can affect the size of the tongue you uncover with your blood tests. Like people, prior to doing a very sophisticated thyroid test, you could have macroglossia from hypothyroidism, but that's so uncommon now because every one of your panels has a check for TSH. Obviously, you don't see it in infants that are congenitally hypothyroid, which is cretins that have large tongues, but that's a thing of the past. You don't see those things anymore with various blood tests that people have done on a regular basis. The so-called black hairy tongue, and immediately the textbook says, oh, it's got to be a fungal problem. It almost never is. It's usually something that they eat that coats the filiform papillae of the tongue. See, the filiform papillae from this point forward have been broken off in what they've eaten. Back here they haven't. It's usually tobacco will do it, and certain foods will do it. If you ate licorice 3 times a day, you'd have that. Certain things can coat the tongue. I don't check for fungus. Obviously, it'd be more important to have these people eliminate tobacco than anything. It's usually asymptomatic. Just an example of this abundant blood supply to the tongue. And thank God it's abundant, because you can bite your tongue, and I can assure you in 3 days you can't even see where you bit your tongue. The reparative process is phenomenal. And that bite is infected with all kinds of organisms in the mouth, so it has to heal secondarily. And how does it heal so rapid secondarily? If you had any other store in your body that had to heal secondarily, it may take 3 weeks. This heals in 3 days, all related to blood supply. The more blood you have anywhere, the greater the healing process will be.
What do you mean by heal secondarily versus primarily?
Well, primary means that there's been a cut. Let's say I have a clean cut, no bacteria. Cut was made, and I suture that up, and it heals fine. Well, it healed primarily because the sides that opposed to heal had no intervening bacteria. Secondarily means that it heals from the bottom up because there's all kinds of organisms in there. Well, if you have a strong immune system, no matter where it is on your body, you're going to heal. Well, the tongue is obviously secondary because as soon as that tongue is nipped by your teeth, you have all the organisms around your teeth that's going to invade. Well, there's an infection there, but the blood supply is so great in your mouth, and the healing process is so dramatic because of the blood supply, it can fend off those bugs in record time, and it'll heal without any problem. Without any problem. In contrast to, let's say you get bit on your arm by a dog, all the bugs in his mouth get into that bite. You wouldn't want to close that, because you know it's going to have to heal secondarily. That's a great thing about the tongue.
I had a neighborhood friend that bit almost off his entire tongue. That's pretty rare, but I think they actually had to suture it. And is that really hard to do?
No. It's a good point to bring up. There are people who can, the ones that we've seen are people who take a good chunk out of the tongue, they're on anticoagulants. And you're going to have to suture it. But I don't get too involved with a good nip. But if it's a traumatic injury of significance, probably the most common one would be someone who happens to be biting their tongue, gets struck on the jaw, or someone who has a major seizure and bites their tongue with a major seizure. You can tear into the tongue and get one of the branches of the lingual artery. All you've got to suture that. Just to control bleeding. But the ones we see are usually, someone in the hospital on anticoagulant. They try to intubate them, they lacerate the tongue, it starts to bleed. They can't stop it. It might be called and put it. Any kind of suture would work. I wouldn't use anything that you have to remove. Any dissolvable suture, and the tongue will heal rather well. But most of the suturing is done to control bleeding. But it'd be nice to approximate some big gap. But once again, it has to heal secondarily. But they do. It's remarkable. This is a little piece of lymphoid tissue on the margin and the base of the tongue that is in response to all the lymphoid tissue that's in this area of our mouth called Waldeier's ring, associated with the tonsil and the adenoid. Here it is, you see it on the base of the tongue. There's lymphoid tissue all through here. Very good. Shazam.
I had a big seizure in the past and had bit a huge